Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm joined by my co-host, Dr. Joanna Richey. Hi, Joe.
Hey, Jeff, how you doing?
I'm doing great. I'm in Florida. It's really warm, but I'm glad we can do these benefit of Zoom. So I'm looking forward to today's discussion.
Me too. I'm really excited about today. We have an awesome guest and an excellent topic.
All right, well, let me introduce Dr. Tiffany Hughes. Dr. Hughes, welcome to Dean's Chat.
Thank you. I'm happy to be here.
We're fairly formal on Dean's Chat, so if it's okay with you, let's go with Tiffany, Joanna, and Jeff.
Sounds good.
All right.
Well, Tiffany, I really appreciate you coming on today. It was such a pleasure to meet you several months ago when we first started talking about Walk with a Doc. And what I'd love to start with is, we'll do a brief introduction and then we'll kind of talk about certain parts of your career as we go through, because we have lots of students that don't really know what they want to do in healthcare. They have some interests here and there. And so I think some of your story could be really, really useful and resonate with a lot of our audience. So Dr. Tiffany Hughes is an assistant professor here at Midwestern University in the Masters of Public Health program. But she got her undergraduate degree from Allegheny College, majoring in neuroscience and psychology. She moved to Tampa, so very much where you are, Jeff, with that beautiful Florida weather, and got her Master's of Public Health in Epidemiology, and then went on to complete her Ph.D. from the same University of South Florida in aging studies with your dissertation, and I'd love to dive into this a little bit, on the role of lifestyle factors in cognitive aging and dementia. So could you tell us a little bit, Tiffany, about what your experience was as a student? What got you interested in neuroscience and psychology? And then how did that translate into where your career is now?
Yeah, sure. Gosh, you're making me go way back in time, I feel like at this point. But so I think Allegheny College was a small liberal arts college, which I think was a fantastic fit for me at the time. And um, started studying neuroscience and kind of saw the logical fit with psychology and became interested in dementia and Alzheimer's because I wanted to know, well, what was happening in the brains of individuals, but also what was happening, in terms of their memory loss and their behaviors that we were seeing. So that, kind of the psychology of it. And then quickly learned that there's not necessarily a one-to-one connection, and that some people had lots of brain pathology. So kind of from the neuroscience of things, side of things. And yet, we're functioning quite well. Their memory wasn't really impaired. They didn't have, the other behavioral disturbances you commonly see. And then there could be the flip, where individuals had very little brain pathology. Of course, these are people that have donated their brains, and but yet walking around, they were not doing well. They had a lot of impairment. And so I was still interested when I went after college to look at more of the kind of biochemistry, the neuroscience side of things. But one of my colleagues, who was a PhD student at the time, was doing a study for his dissertation looking at a mouse model of dementia, but putting them in essentially an environmentally enriched environment where it was kind of like, when you have a pet mouse, you give it all the tunnels and the wheels and put them together in a social situation, and then compared them to the mice that we typically use in research that are just basically in a shoebox sized environment, maybe with a few other mice with them. And this led me down the road of, wow, like if the mice are enriched, you actually saw that their cognition and the way that we tested in an animal model was less impaired, despite having the pathology of, another mouse who was living in that kind of standard shoebox environment. So it led me to think there's, ways that perhaps we can be living our lives through, physical activity, social engagement, the mental stimulation that might do something, maybe not necessarily to the pathology, but at least, allow us to continue to live and function more independently and not see the decline outwardly speaking. So that was really fascinating to me. And then that's when I jumped into graduate school and focused on aging studies, and then just kind of started to more broadly explore what happens as we get older, normally speaking, and then what some of the pathology is related to cognitive impairment and different kinds of dementias. And then because I was interested in more of the prevention of it through lifestyle, that's when I brought in the public health perspective and epidemiology and understanding, well, what can we do? Not that treating it isn't important, but what can we do to prevent it or at least delay it? When we talk about dementia research, because it's an age-associated disease, we often talk about delaying it long enough that the person would pass away before they would even exhibit the symptoms. So prevention through delay or even prevention altogether. So that's kind of where that led me to my dissertation topic of looking at modifiable risk factors. And then I think that's really been kind of the flavor of my career, is looking at different things, largely in the kind of individual behavior environment.
Jeff, what are your thoughts?
Oh my gosh, I love this topic so much. My mother passed away from Alzheimer's, and my father had vascular dementia, and they lived a very healthy lifestyle. They were runners and they were vegetarians over time, and they seemed to be doing all the things that one would think you'd do to delay or the onset. And maybe it did. I mean, you don't know.
Right.
But my gosh, can you talk about prevalence and what we're expecting in the realm of dementia as we go forward over the next several decades?
Yeah, I mean, just with my training in aging studies, we know that we have a growing aging population, and I prefer and try to educate others to try to not use some of the terms we hear out there like aging tsunami and things, because I think it kind of has a negative connotation. Aging, an aging society can have a lot of good things, right? But just by virtue of that, and like I said earlier, with dementia being an age-associated disease or condition, we're going to see more people with this condition as just, but there, I think prevalence-wise and from an epi perspective, we also are seeing that there are some things when you look at cohort studies that perhaps we're moving in the right direction, because we know things like education is one of those risk factors that the more educated you are, the less likely you are to develop dementia. And we know that our society is becoming more and more educated. So as cohorts, are more educated, we're hopefully going to see that contribute to a decrease in the occurrence of the disease. And some of the same other, hypertension's another big factor, and we're controlling it better than we used to. So I think, we're probably going to see a little bit of, yes, there's going to be that increase 2030, 2050 now, that's just by nature of our aging population, but yet hopefully we're kind of counteracting it with some of the things that we now are learning are important and just, is happening in our society to combat the risk factors that we're aware of.
One more question for you. I've been doing lots of research on this exact topic, and I'm looking at putting a sauna at my house based on those Finnish studies that showed, I think it's upwards of 60% decrease in development of dementia if used 3 or 4 times a week. It might be too late, we'll see, but there's always new studies coming out, right?
And I love that you just said it might be too late, because I guess as a gerontologist, I like to hope that it's never too late. Perhaps from a life course perspective, the biggest impact is if we live a healthy lifestyle, forever, but that's oftentimes not reality. But I still think a lot of these modifiable risk factors, we can still do something about even, after what we would consider, later life. So if you learn about it and there's an opportunity and there's not any other potentially harmful effects from it, then start it.
Absolutely. Thank you.
I'd love to jump on that, because you've published pretty extensively in lots of different areas in terms of geriatric studies, dementia, and also movement, which kind of beautifully translates into some of the topics we're going to talk about. But highlighting a couple other things, you did do some additional postdoctoral training in the field of geriatric psychiatry with the University of Pittsburgh, and also got your master's of business in healthcare administration with Youngstown State University. Can you talk a little bit about how those two experiences have impacted maybe some of the approaches that you take or the way that you look at different opportunities in the space of gerontology and adult education?
Yeah, sure. So my postdoc in geriatric psychiatry at the University of Pittsburgh was a wonderful mentoring experience. I still work with the group to this day. And my mentor is a geriatric psychiatrist by training, but also an epidemiologist. So she runs a large cohort study that's been going on now for nearly 20 years, but had other studies that were happening even prior to me joining the team. And through those experiences, I think, to me, what I learned was really, how to conduct research. That was the big lesson that I took away from that and continue to learn still from her. And just how there's so many, different the cohort study has so much data and it's very rich data focusing on the cognitive outcomes, but that gave me the opportunity to look at movement and physical activity as a predictor and look at social aspects of your lifestyle. Even delving into adding a measure of the Florida Cognitive Activity Scale, which was familiar to me from my graduate studies, and adding that into the study. So it gave me a lot of different opportunities. And the University of Pittsburgh has a lot of different resources, faculty involved in aging research, geriatric psychiatry, neurology. It was an Alzheimer's disease research center. So just a lot of resources were available to, network and collaborate with people in different areas. My MBA came later on in my career, but just kind of, I've taught in the space of dementia from different multiple disciplines and appreciating that, you need to look at it from what's happening in the brain to how you prevent it to how it impacts caregivers, what the latest, pharmaceutical treatments are. And I don't claim to be an expert in any of those areas, but I just appreciate from a gerontological perspective that it really affects the person, holistically and even their families and our communities. But the policy part of it was really kind of what led me to the business side, right? And kind of trying to understand even how to advocate. And that was so that degree was recent. But since coming to Midwestern, I've gotten more involved in the Alzheimer's Association here in the Desert Southwest chapter so that I can be an advocate and kind of understand what's happening locally and, even nationally in terms of what we're doing policy wise, and just hopefully have enough expertise now that I can offer some of my knowledge to help, them make some decisions. And it's just, and then I was just at the state capitol day that they have every year. And a lot of the advocates are individuals who are caregivers or had been caregivers for someone with this disease. And to see, it's really important for me as a non-clinician, though, to connect with those individuals and just to remind myself of why I'm studying what I'm studying and the impact that it has on them. And, they're advocating from a little bit different perspective. I'm trying to impart my knowledge from the academic. And also, I think also being here at Midwestern is really hopefully trying to get more students interested in working with this population, or at least being educated about working with this population even if they don't choose to.
I love that. And that's something that, again, when we first met, that I instantly bonded with you over, is really this opportunity to engage with a demographic that has such a huge impact on quality of life, mobility, and independence. And I'd love to kind of transition a little bit into some of your experiences that you've had with geriatric education. You've done lots of different, as you talked about, interdisciplinary, and looking through all of your research and your presentations, Tiffany, it is so humbling how many different areas that you've really looked at. And I'm terribly fascinated by some of the experiential opportunities that you've looked at. So can you talk a little bit about some of those different studies that you've done, and then kind of we'll transition then into how you found Walk with a Doc and how that fits into your whole perspective.
Yeah. So I think gerontology as a field, it's a newer discipline. And we really do look at aging from all areas. And when I started the position at Youngstown State University after my postdoc at Pitt, I was teaching aging, like, and broadly speaking, right? And some of it was out of my comfort zone and kind of had to learn. And then I was teaching graduate students who wanted to take on a capstone or a thesis project, and very much out of areas that I did not feel that was my area of expertise. But it was fascinating. And I think that's kind of like why I love academia so much too, is because even though, you know, we're touted as being sometimes the experts in areas, like I just love to learn and I love to give my students the opportunities to still teach me. And then with respect to, and I mean, I guess that speaks to kind of the breadth of how I've, kind of gotten involved in so many different topics. Is just sometimes it's a lot to do with my students and what their interests are, and me just being able to mentor them. Um, but with respect to the experiential learning piece, um, so I was always taught hybrid in the sense of some in classroom and some online. And in gerontology, we felt like, for lack of a better way to describe it, it's just not a sexy topic. And it's really hard to get students interested in, when they're in their, the traditional age student anyways, interested in studying aging and working with older adults. And we were seeing a lot of our students that we had were oftentimes coming back to school. They were maybe, middle aged, who had already cared for an aging parent and had life experiences where now they understood why it's important to understand the aging process and, to help support their families and age better. But so the experiences is where we thought this is where we can get them, because oftentimes when you give them those opportunities to be around older people, and right now we're living in a more age segregated society than we ever have in the past, a lot of students they're not around even their own grandparents, more or less older adults. And we wanted to bring them together. So we started with, our undergrads, freshmen, sophomores. We would just make this volunteer opportunities in our classes. And then as they got, juniors, seniors, we built them into our classes. And that's where I found programs like music and memory, where I would take students to a long-term care facility and they would sit down and get to know the music preferences of people with dementia and help them put it on iPods. And I'm not going to take any credit. Most of the experiential learning programs I've done have been programs that exist. I just brought them to my students. Another great one was where students would do, like, it was life bio. They would interview residents, not necessarily with dementia, but just to get to know them. And then that company puts it together in a book, an autobiography that the families can have forever and share. The OMA project is one I'm also doing now at Midwestern. This is called Opening Minds with through Art, and it's a program that was developed also in Ohio. But it's just an amazing opportunity to educate students about dementia, because they're paired one-on-one with an individual living with dementia and do art with them. And it's just a fantastic way for them to see how people with dementia can still create wonderful things. They haven't lost everything. You focus on what's still there. And I think, ultimately, I feel very passionate about these opportunities are really what get students thinking about working with this population that may have not otherwise crossed their mind if they had just had a lecture on it or read an article about aging processes. So that's why I get excited and want to try to at all costs, because sometimes experiential learning and working with community partners adds more to our plate than a typical lecture-based course does. But I feel it's really important. And even now in the MPH program that is 100% online, I've sought out these ways to keep going and still engage with students in these opportunities.
Oh, I love that.
Joe,
Jeff,
isn't
what are
it
your
funny
thoughts?
how student engagement, it cuts across all fields? Um, Tiffany, one of our biggest challenges is the transition from going from slides to experiential opportunities, that once the students have them, they never forget them. Handling instrumentation for the first time, and
Mhm.
some of the different new technologies we've brought to our labs. So I can see that for sure. I see it in my kids, for example. They don't appreciate, because like you just said, they're younger, they can't relate for what's going on with their grandparents, but that opportunity to spend time with people as they go through these changes is interesting. One of the interesting things I thought when I've been interfacing with elderly adults is their need for familiarity, and maybe that's what they remember the most. But I know as we were working with my mom over time, she always wanted to go home. I always wanted to go home, and that transition process is so hard. And unless you've got professionals helping through that process, and not only helping the patients, but helping the families and the caregivers, it can be much more challenging than it needs to be. So kudos to all the training you're doing and giving these students tremendous opportunities.
Thank
And I
you.
think that's an important point too, when you were talking about understanding the policy. There's so many fragmented parts of our healthcare system. And, I've seen this with other clinicians when we talk about things like fall risk, and it's like, well, we can send out, the medical assistant can fill out a questionnaire, but then it's like, well, that's not my job. Like that's, we'll refer them out for that. But again, when you're dealing with a 70 or 80-year-old patient, and it's, oh, call this number, make this appointment, and they may or not know why they're doing it, what the point is to doing it. If it wasn't written down, they're not going to remember. So they're figuring out how we can really optimize this for our patients so that we get better outcomes. And so I actually thought that, again, what a great opportunity to learn a little bit more, figure out how we can impact the most positive effects as part of a system, because we have to play as part of the system. They're trying to keep us all in these silos and not work as a team has not proven to be very productive. Can you talk a little bit about how you found Walk with a Doc? Was that something that you sought out yourself, or was this something that kind of was presented to you? How did that kind of happen in its early stages?
So when I was at Youngstown State, I think we've talked a lot about dementia, and I know we're getting to falls, but when I was at Youngstown State, and in gerontology, we had a steering committee where I met a colleague interested in geriatrics, but she was a physical therapist, and explained to me how she was doing a program at a long-term care facility where she would just take her students and do the study toolkit quick assessment. And she needed to get some research training, and I was like, well, you know what? Let's partner up and let's do something with this. And I was also interested in the cognitive piece. A lot of older adults with dementia fall. I mean, they just go hand in hand, unfortunately. So I was interested in, let's expand, let's do study, let's make this research. And so she and I built that together. She was the one who was doing the Walk with the Doc with her DPT students. And so, she invited me, we would do monthly walks at the mall, and I would participate, about once a year, I would be the speaker. But, she had several speakers come in, and the DPT students would participate, do the blood pressure checks and do the walk and whatnot. And then this was before COVID. Then COVID happened. Of course, everything changed, things were put on hold. And then after COVID, we were just starting to put together a senior center that I was partnered with, was transitioning to becoming an intergenerational center, where I was kind of the lead connector through the university with the intent of trying to get more of those experiential learning opportunities built into the curriculum at Youngstown State. And due to other circumstances, her ability to lead Walk with the Doc wasn't really on her plate at the moment. So we decided, let's revive it. Let's, get it going again. And so that's where I kind of came in as kind of having a bigger role in leading Walk with the Doc. And it was really a partnership between the university and that intergenerational center. We took it on together to try to bring it back and bring more students to the walks, even beyond the DPT program. And then when I, came to Midwestern, I thought this was such a great program, and was actually kind of surprised. It has expanded nationwide. It is in almost every state, but it really wasn't represented well in Arizona at the time. So I thought this would be great. Plus having if we know falls happen, we can look at it from so many different perspectives from a healthcare system lens, and now at a university focused and having so many different programs, I felt like this was a wonderful opportunity to get all the programs, or as many as I could, involved with this project or this initiative.
Joe, I did a little research on Walk with the Doc, and it started in 2005 in Columbus, Ohio, so not far from Youngstown. And Dr. Sabger, his idea was he wanted to help patients get more active, and he was providing education, exercise, and empowering them to participate in their own health. But I thought it was interesting because at the beginning of every session, they do a 3 to 5 minute discussion on a health topic. And I just it apparently it's grown tremendously because I read it's in over 400 communities around the world. So Tiffany, you're onto something there.
It's another example of where I don't take credit. I just found something that's wonderful and I'm like, let's do it here.
Right. I mean, what a great opportunity. So once you got it started, how did it work in Arizona? How did you get the ball rolling?
So with my interest in falls and wanting to get to know others that were doing fall prevention work, I was in Ohio. I was part of the Ohio Fall Prevention Coalition. I think that's what it was called, something to that effect. Found that Arizona has the Arizona Fall Prevention Coalition. And so just, poking around on the website, I found who to get connected with and was able to join a meeting. And I think my first meeting, they had asked me to present on what I was doing, which was a great way to, get other people to know who I am and who might want to work together. And so to back up, I had the fall research that I was doing at YSU was not directly connected to the Walk with the Doc program. But in my head, I felt like they could be for sure. So when I presented to the Falls Prevention Coalition here in Arizona about my research related to falls, I then ended with, wouldn't it be great to use the Walk with the Doc program or platform to educate, at least to start, about falls, and then maybe it can lead to more from there. And they were like, yeah, let's do it. And in no time, they took on getting a charter. And at this point, it's kind of a blanket charter. There's other walks that they support in other parts of the state. So we're just one of a few. And as the new co-chair, education chair, my goal is to even see if we can get the coalition to keep building more walks around the valley and across the whole state. But yeah, it was without their support, I wouldn't have been able to get it off the ground, but they kind of let me roll with the idea that we could have one of our walks here with Midwestern and really bring in this, again, not a new idea. Other universities are doing this walk with a future doc, which is what we're doing, is allowing our students to be even the walk leader under the supervision of our faculty. So it gives them an opportunity that's unique, I think, to some of the other walks, but we might as well capitalize on what we have here at Midwestern. And so they're kind of giving me the freedom to develop the walk, and that's kind of where we are now.
Yeah, and I have to say it was such a fun. So we had our very first one just last month, Jeff, and our students were a big portion of that. And that first little welcome chat that we had was really all centered around what podiatric medicine is and how foot function impacts stability and fall risk reduction. And it's really interesting. I think even some of our students were humbled by some of the statistics that and not to center all the discussion here, but certainly for the population in our audience that's listening that are providers of care, every second an older adult falls. That's the average estimate. And so that is a lot of falls every year. And a quarter of the adults that are over the age of 65 that fall at home, and half of them won't tell their healthcare provider. So this is something that's not being talked about. There's a lot of stigma and there's a lot of shame, I think, that our elderly population carry, where they don't want to talk about this because they're afraid of losing independence. Mm-hmm. And as I've certainly had the opportunity of working with a highly senior demographic in various parts of my own career, as I started to figure out how important it was to really ask some probing questions to get a gauge of how safe someone's going to be But unfortunately, most of my career, it was all after the fact. I was asking all these questions in the emergency department when we're sending them home with their broken ankle, trying to figure out how we're going to get them fixed for surgery. And so transitioning that then into, okay, well, how do we make the surgery better for these high risk patients? And again, that's a wonderful area to focus on. But then you just start to realize that there's got to be a better way to do this. And so trying to figure out where the opportunities are to prevent falls. And just for my own education, when I kind of stumbled upon the steady approach, it's so simple what we can do as doctors to help patients keep their independence, keep them at home safe. And that's what their children want for them as well. And so I'd love to get your take, Tiffany, on and we'll put links in the show notes to the study in case people want to learn more and get more information. It's a program that was developed by the CDC. But can you talk a little bit about what your experience has been with study? I know there's been some publications that you've had looking or using that system, kind of what your experience has been.
So again, my colleague in physical therapy introduced me to this toolkit that you said the CDC created, obviously with lots of input from different experts across the field. But it was really just, to streamline the process, right? And make it easier for providers to screen. But so our intent was, well, let's just use that in the community. And but we enhanced it a little bit because I was interested in cognition. So we added a cognitive screener. But ultimately, the other big part of it was at the end of our assessment, which was research focused, but still from a clinical kind of lens too, was giving them the study toolkit. And we gave them the results. The study algorithm, it's so simple. Even during the research process, we were able to, follow the algorithm and give them their fall risk level. And so we had, designed a way to communicate that with them, another way for them to communicate that to their healthcare provider if they wanted to, and then give them a free study toolkit because you could order them from the CDC with our goal to not just only, increase awareness about it from the patient's perspective, but also hopefully they would share it with their providers. And I was kind of shocked because being part of the Falls Coalition in Ohio, we had a meeting every couple of years. And, a lot of people weren't even aware that the study exists. And so that was kind of where we led to why we wanted to, share it more broadly, because, it's not just a PT tool, it's other disciplines, as you are aware. And so, everybody should be using it or can be using it because, falls it's a teamwork that needs to come together to really ultimately, do our best to prevent falls. So I just think it's a great resource that's out there. And just, we wanted to increase, people's awareness of it and hopefully adopt it in their practice.
Absolutely. And I think your point there too about these are free resources. They're accessible to everyone. When a lot of times I would have kids reach out to me about their parents. They don't live in the state with their parent, but their parents coming in for an appointment and the staff would route me these messages. And again, it was interesting to see there are some very simple things that just over the phone that you can ask your family member, like, do you feel steady? Like, do you feel like you're going to fall? Is an easy one to ask. Have you fallen? That's another really easy one to ask. Have you fallen in the last year? And it's sometimes the things that are the easiest things to do are the hardest to kind of implement. But from a policy perspective, these are also now Medicare, MIPS and MACRA or whatever they're calling all their incentive stuff now. So these are things that are important for us to do. And it's been really fun, Jeff. We've been instituting this in the clinic across the street, and our students have had the chance to, if patients say yes to those questions, then we can perform some very simple assessments to see if they're really at risk. And Tiffany, I know you've looked at, one of your studies was looking at seniors kind of self-graded how well they thought they did at balance. Mm-hmm. And so again, I'd love to get your take on that because obviously one of the simple things we can do is some tests on balance. So can you talk a little bit about some of the work that you've done in terms of what patients perceive they are able to do versus what they're actually able to do when put to the test?
Yeah, so we added a measure called the activity balance confidence scale, the ABC, you may be familiar with, and it has them answer questions about different kinds of activities on a scale of 0 to 100 on how confident they would be. And that was because there's a lot of, it falls under the realm of, that's confidence, but there's also this idea of fear of falling where people, they might have had a fall and then they're fearful so much that they stop doing all the right things like exercise that then would, prevent another fall because of that fear. But our study was just interested in what the kind of the connection or disconnect, if you will, was between how people feel about their confidence in their balance versus what the study algorithm was telling us of whether or not they're at risk. Because I think that kind of, there's the people that we considered the worried well, that were the people who, according to the study algorithm, they were not at risk of falls, but yet their confidence level was pretty low. So, and maybe that's okay, right? Hopefully that means they're probably taking more precautions, hopefully not too much, but the right amount of precautions to lower their risk. But then there's the people that were not aware, right? So that meant that, we're like, okay, your algorithm says that, you are at risk for falls. Yet when you ask them about, how confident they are doing different kinds of activities, they seemed very confident. And so we're like, okay, these are some people that maybe we need to, think about, doing some kind of perhaps intervention in some way, right? And where do they fall into it? And I think more importantly, the study is a wonderful resource and toolkit, but we were wanting to just understand like, well, there's all these ways you can make things better and that maybe providers could do. And we used a longer version of the ABC. There are I think more brief versions available, but maybe like you said earlier, there's just those few questions. Maybe providers, if they just needed to ask like how confident someone is, it could also add more context to how they're working with their patients, knowing that piece of it. And then that might kind of help steer their conversation and the way that they work together a little bit differently.
And especially, and Jeff, I'll pivot to you in just a second, but I loved that it went a little bit further than just asking those questions. Because certainly in my experience, especially the patients that maybe don't want to talk about, they're not going to answer like, are you worried about falling? They're going to be like, nope, not at all, right? Because they want the questions to stop because they're afraid of not keeping their independence. And so what I love about something as simple as like the 30-second chair sit stand test, right? You just have them, can you do this? Because even if they genuinely feel comfortable and confident, like, oh no, I'm fine, sometimes helping them see where there might be some weakness or some deficit that maybe puts them at a higher risk. And this is preventable. We can do something to make that not happen rather than just be like, oh, well, sorry, I guess you don't have enough lower body strength. And now that's just how it's going to be. No, that's not it at all. The goal here is to keep you at home, keep you active, keep your independence. But hey, maybe we need to work on that specifically, and then we can get the proper referrals in place. Mm-hmm. And so that's been something too that I know our students have really enjoyed that opportunity to help. We can tell patients something like, oh, you need to do X, Y, or Z. But if they don't feel like they need to do X, Y, or Z, I'm a human, I'm not going to do it, right? But when they can be like, oh, wow, that actually was challenging for me. That was really difficult for me. And you're going to offer me an intervention that maybe is going to help. Oh, that's great, right? Like everyone is winning in that situation. And so I loved that study that I only recently read it when you sent me your CV, and it was like, oh, this is so useful for what I see clinically versus kind of what people tell you. This is how you should be doing whatever. But yeah, so I appreciated that so much about this idea of overestimation and what they're actually capable of. So Jeff, what are your thoughts on some of the discussions we've been having on patient care? And
well, I think the self-awareness component is huge. We see it in every aspect of our practices. I mean, patients don't even want to take their shoes and socks off at the primary care doctors if they have a wound on their foot because they're afraid they might have a recommendation for an amputation. So that self-awareness is important. But I also think that connection with walk with a doc is important because it's an environment where there's not a lot of pressure. Nobody's in a rush. They can become aware of situations that they maybe are looking the other way on. And then they feel comfortable in a group, perhaps discussing where they're at in terms of stability or falling or walking or any of these topics. I think that providing that environment where there's no fear and there's acceptance, patients respond so much better. And that's why I think that walk with the doc or walk with the students or anything that empowers patients to help make decisions and have a greater sense of self-awareness is something we need to keep feeding. If you keep feeding them, if you will.
Yeah, 100% echo that. I didn't even realize at first, but how important it is that, providers don't always have the time or appreciate the need to assess for falls, and patients, for all the reasons we've discussed with the stigma and fear of losing independence, don't want to talk about it. But the Walk with the Doc platform is just a really great opportunity. Not just I think even if we didn't have the students involved, it's just, the informal atmosphere helps. But then we have the students, and I just think that just hopefully, encourages a lot more conversation and opportunities to ask questions you might be afraid to otherwise. So I think this is a really good opportunity for us to have more conversations around fall prevention.
Well, especially at Midwestern with the interprofessional emphasis, we have the DPT program right across the hall, and we teach in their courses, they teach in ours, and the more we can work together to meet the needs of our patients, the better off they will be. So I love it.
I mean, I guess the third piece for me is we're educating the community. There's opportunities, secondly, to talk about things that might be hard to talk about. But then when we have these walks, like when Joanna brought the podiatry students, there were still other students from other programs there, right? And they're hearing that message, and we hope that that is the model we have every month, that we have a different speaker, is that students from all different programs hear the message about how their colleagues in other professions are working to prevent falls, and then it really hopefully emphasizes the intercollaboration.
It's like redefining the community educational experience.
I like that.
Because sometimes in Midwestern we go down to the library and each of the colleges takes on a lecture that is very driven to the lay people, that isn't very technical but really gets this message across. But it doesn't involve that walk and the exercise and kind of that environment. And maybe it is a new way to connect with our patients in the community. It's great.
And that social part,
Yeah.
the blue zones has been a big thing that has
Mhm.
popularized, maybe it's not new, but has been popularized recently. And the social component. So, and that's again, as I've learned more about Walk with the Doc, the casual nature. So again, it's not intimidating to
Mhm.
either practitioners or patients. It's just fun. Like, let's get out and take a walk together. We don't even have to talk about falls if you don't want to. And maybe it just starts to come up, right? The social part, you start to meet people. And I love what you're doing, Tiffany, where you have different programs hosting it every month on campus. Because again, collectively, to your point, Jeff, we all get to work together, and it's another opportunity to engage with each other and foster this collaboration that ultimately improves patient outcomes. And it's fun, like getting out and walking, just taking an hour out of your day to just go be outside and enjoy our beautiful campus. Like, that's such a wonderful opportunity. With the social part, Tiffany, what
Mhm.
have you seen in terms of some of your previous experiences? Do you get a lot of repeat frequent flyers, or what's the social part been like?
Yeah, I mean, for me, the social part is probably one of the biggest parts. I'm interested in isolation and loneliness, kind of, in relation to dementia, but, other health outcomes as we get older. But um, when I was a postdoc, I believe, I did a study where we looked at using the Wii games. Remember that when that was
Yeah.
popular? And I did it as an intervention for people that had mild cognitive impairment. And we did it in small groups and didn't really anticipate, but really what the secret sauce was that they all liked each other and just kept coming, not because they wanted to play the games or because it was had anything to do with, lowering the risk of their cognition declining. It was just to see their friends. And I went on to teach silver sneakers later on and just saw the same thing, that they had such a community. And so I think, for things like exercise that, it's kind of tough to keep people motivated to do, bringing that social component, in, um, can be really what keeps people coming back. And so I know that we did certainly see people coming, to walk after walk. And I think, to the point of, they get to meet new people in the community, peers, but also the student. Like a lot of them come, the social connection they have with the students, they talk about, like, it really gives them a different purpose too. Like they love the idea of being able to contribute to the students' learning experience and giving them opportunities to, practice their communication by either delivering the health talk at the beginning or just walking around with them and talking about health topics. So they really like that. A lot of them may be, especially here in Arizona, if they're retirees, they might not have their grandkids or other kids close by. And so they like that social connection. So I think that's another unique piece that we have at Midwestern with our students. Not that all of our students are, the traditional age, but largely speaking, that's kind of the demographic we have.
That's
I
right.
love that.
Tiffany, would you mind giving a plug for the MPH program at Midwestern?
Absolutely. Thank you and I guess that's where all this, prevention and, all its upstream, the policy that, looking at things we can do in the community and the individual behavior changes, that's all public health focused, right? We want to try to keep you away from all of the clinicians that we're training Midwestern students to be, right? But ultimately, it leads to better patient outcomes. It leads to, it's not just primary, we're secondary, tertiary prevention as well. And hopefully reduce healthcare costs. But yeah, so I think the public health program is a really nice complement to just about every program we teach or have available at Midwestern. And so if students are interested in learning more about that, we have the program that's a dual degree program. We also have a standalone program now if students want to do it perhaps as a lead-in to another primary degree, or even after they just kind of want to add that as another credential. But it's really been a great way for students so far that have done the dual degree to make themselves stand apart, as they get ready to go on to the next steps and are interviewing, they have experiences that they might not otherwise have that I think make them more marketable in the job in resident, opportunities.
Absolutely. Thank you. Joe, other thoughts?
No, I'm so grateful for you reaching out about this opportunity and for having the chance to be involved with it. I'd love to plug. I'm not sure exactly when this one's going to be released, but I know we have one coming up in February, which is very soon. So can you plug the March date if you know it? And then maybe we can.
Yes, it is March 21st. So it's the same, I guess the way that February, March dates land, it's the same. So it will be March 21st. And that walk will be students from occupational therapy. And Holly Jones is the faculty member from the program, and she'll be bringing students. So we're excited about that one too.
Fantastic.
And I need to say thank you very much, Joe, for participating in the first walk and helping get things off to such a great start, and just really being an advocate for this and helping it to grow and become hopefully something that Midwestern, takes as a, point of pride.
Absolutely. It hits all my core values. So I love it all. Anything I can do to be helpful.
Thank you.
Tiffany, thank you again for joining us on Teens Chat. We're going to make this required listening for the podiatry program, and then we'll get it out to everybody at Midwestern. And also then to our listeners, if you're listening on Apple or Spotify, please give us a 5-star rating or perhaps leave a comment. And if you're watching on YouTube, please become a subscriber. And until next week, cheers, everybody. Oh,
cheers. We're going to get you a mug, Stephanie.
yep, we're sending you a mug, a Dean's Chat mug, Tiffany.
I'll use my water bottle.
There you go.
Sounds good. All right, good. Bye-bye, everybody.
Bye-bye.
Bye.